So the quality improvement in patient care. It is generally saying patient care, but if it is, because if it is asked in our question, we have to include our own specialty practice, how we have to improve in delivering the patient care by proper anesthetic technique in collaboration with the surgeon, because anesthesia is mainly dependent on surgical collaboration also, and without a surgeon we don't have any work to do anything for the patient. So the word quality uh, describes the degree or grade of excellence of a trait or character. This is a Oxford dictionary meaning of the word quality. And quality improvement is facilitated only when you have an interdisciplinary group of healthcare. We as anesthesiologist alone cannot do any improvement in the quality. So we need the cooperation and interdisciplinary support from other people. For example, even if you want to do a surgery in a patient in the OT, you cannot just like that go and anesthetize the patient. You require a proper ward boy, you require a stretcher bearer, you require a scrub nurse, you require a circulating nurse, you require a ODA assistant, then only you can start your case. So it is a we depend on so many people on our own specialty, plus it has to be a cooperation between the other departments also. So it is mainly an interdisciplinary group, healthcare providers, who regularly review their performance. If you want, because this word says improvement, you have to review your performance and see whether you are doing it with satisfaction to both yourself as well as to the patient. That can be achieved by only a regular periodic review meeting. In our, when we were undergraduate and postgraduate students, we used to have what is called audit meeting every month, where all the complicated cases or mortality cases will be discussed, presented and discussed with all the, it is a compulsory attendance, and anybody can question about the nature of the treatment, diagnosis, faults, or failure to do a proper investigation. Everything can be questioned. That is called the audit meeting, which you can now say as a review of performance, which will help to identify any deficiencies in the treatment and try to design interventions for improvement and create a team of impartial interventions. So these are the three basic fundamental things of a quality improvement. One is you have to review your performance, then you have to design interventions, and then create a team to implement the interventions. So if you do these three things, you will be able to provide a constantly improving patient care in the hospital. So it is common to describe the improvement in terms of patient safety. So always you think of patient safety, primum non nocere. First of all, do not do any harm. That is an important quote that has to be followed in our medical practice. So the improvement is not limited to preventing mistakes of commission, but also mistakes of omission. So when you start treating, you can make mistakes. That is called mistakes of commission. But by not properly doing the treatment or trying to do an intervention at the right time, that is called mistake of omission. So we have to avoid not only the mistakes of commission, but also mistakes of omission. Now coming to the historic methods of assessment, earlier it was called quality assurance, as I told you, and it consisted of review of adverse events or defects, morbidity and mortality conferences, isolated liability claims, and incident reporting. This is a very, very important thing. If any complication happens in your OT or in your ICU, these things should be reported and this should be discussed. We had a very good system in Stanley when I was working with the hand surgery department for more than nearly 19 years. Every day morning at 8 o'clock, before starting the theatre work or ward work all the surgeons of the plastic surgery department used to assemble in a conference hall, and the surgeon who was on duty the previous day will have to enumerate the total number of cases that looked after in the emergency, out of which how many were minor, how many were moderate surgeries, how many were major surgeries, and then what was the diagnosis, what was the plan surgery that was done, everything he has to describe, and all the members, other members had the right to question or clarify any doubts that they have or point out any mistakes like commission or omission in that. And after that discussion for about 45 minutes to 1 hour, then only they were dispersed to go to the OT or ward or outpatient, whatever their duty is. So that is a sort of routine that has been going on. So this is a review of not only adverse effects or defects, but also about other things, which is a very, very important thing. So remember these 3 points of review performance, design interventions to improve, and create a team to implement whatever improvements or interventions that have been thought of. Then the information provided by the above were haphazard and biased. This is coming to the historical or the review of how it developed, this topic of quality improvement, how it was nurtured is. So they focused on assigning blame rather than to reduce the risk. That was earlier why people were not reporting the incidents. Supposing, for example, you give an epidural and it becomes a total spinal, and inadvertently you make a puncture in the dura, and instead of loading the drug in the epidural space, you give it in the subarachnoid space, and patient goes in for a total spinal and as a cardiorespiratory arrest. And you somehow revive and everything goes on well, patient recovers. But you are afraid to go and report it because you may have a guilty feeling that you have done something wrong, or you may have the feeling that people may think that you are inefficient and you have caused a mistake. So because of this reason only, incidents were not properly reported and mistakes were happening. And when it got blown up in a big scale, like the patient attenders making a ruckus and then trying to sabotage the hospital, try to beat the doctors or damage the properties, then only it came to light. But if you have a system where you can report that and then try to identify it early, then steps can be taken to avoid or improve on that particular mistake. So the ASA began what is called the closed claims database in 1985 to collect information about rare but catastrophic events. So as early as 1985, they thought something has to be done to prevent this sort of blaming each other, and we must try to reduce the risk to the patient. So patient safety became more important. So the information received was the impetus for the development of quality improvement, safety, and educational programs with the goal to reduce the risk to the patient. So that is how this whole system came in. This is a short history about the quality improvement. And they formed what is called the ASA task force. So whole thing started in the USA. American Society of Anesthesia Task Force to establish guidelines for. It initially started in our specialty with difficult airway, and then voluntary incident reporting identified as hazardous systems have been used also to foster quality improvement programs. Now, what are the measures of quality improvement? Healthcare has borrowed tools from other disciplines like organizational psychology, sociology, human factors engineering, that have developed basic quality and safety relations. So industrial units also have this sort of problem. There are chances of accidents occurring, especially in the major industries. People, especially in Stanley, when I was there, North Madras was full of industrial belt. So we used to get a lot of hand injuries, and the whole department was started with the idea to treat those patients who suffer their injuries due to the work-related machinery-induced injuries to the hand. So other departments, non-medical departments are also trying to improve their quality, and that is how the whole thing came into be incorporated into our medical system also. So at the end of World War II, it was Edward Deming, an American statistician, who introduced the concept of quality improvement in the industry. This led to modern day science of improvement. Now, what are the process and outcome? Quality improvement measures an outcome, that is morbidity, mortality, length of hospital stay, quality of life, or perception of care. These are the things that are the outcome of a good quality improvement. If your quality improvement is good and you are delivering a good service and care to the patient, the morbidity, that is complications, should come down, mortality rate should come down, patient should be leaving the hospital without infection or secondary wound lesions or other problems. They should leave the hospital as fast as possible, and they should get back to their original quality of life, and the normal perception of their life should be back. So this is the main aim for quality improvement. So what is the process? For example, for beta blockers for coronary artery disease, or a structural measure, ICU physician or nurse staffing ratio. So these are how the process is started. Either it can be a pharmacological introduction for a particular disease, or it is a when staff related or a physician related structure that helps in the process of improving the outcome. So periodic analysis of quality improvement data help in deciding how clinical and statistical significance can be attributed to that. Now, what are the examples of quality improvement programs and tools? So one is voluntary incident reporting. This is a very, very important basic criteria for improving quality. That's why I gave you an earlier example of how an epidural attempt can result in total spinal or a failed intubation, not taken care of properly, patient going in for hypoxemia and going in for hypoxic brain damage. All these things are all incidents which have to be promptly reported. So example, prescribing an antibiotic in which the patient has informed that he is allergic, but still you go ahead and do it, or negligence can be reported to analyze how the error occurred. So this is a general rule for all the patients and other specialties. But examples for our department can be wrong drug administered in the spinal, or failure to recognize a difficult airway and landing up with a problem of can't intubate, can't ventilate scenario. Now, across clinical area and across multiple healthcare organizations to improve collaborative involvement of participation is very, very important. And there are 4 steps that have been described to improve the quality. One is engage, that is make the problem real and share the information. This is the first thing that you have to do the quality improvement. Second thing is educate. Develop a plan to educate members of caregiver team. For example, if you have a case of difficult airway not managed properly has occurred in one OT, this should be discussed in the department with all the members from the senior most to the junior most, and then you must analyze how it happened and educate the juniors or the freshers whoever is going to handle the cases in future, so that they will be aware that there is a problem of what is called difficult airway. How you have to be prepared will be known for everyone. So the chances of such mistakes being repeated or occurring again in future will be very much prevented. So first thing is engage all these people, share the information, then educate, develop a plan to educate the members of caregiver team, and present EV practice at grand rounds and multidisciplinary meetings, and present plans to improve outcome. This is for a general to all the departments, not only anesthesia. Then the third thing is, after educating, you execute whatever you have taught by developing a safety culture, reduce complexity of process, introduce redundancy, and hold regular train team meetings. By doing this, develop culture for intolerance or crime, making blames. So try to avoid blaming the person. That is very, very important. That will ridicule the morale of the person. So mistakes can happen to anybody at any time. So it is the cooperation and the discussion to prevent such things happening in future should be the idea, and not to find fault and blame the person, which was happening earlier. As I told you, the historical development of quality improvement, that is the main reason why voluntary incident reporting was not taking place. So make certain that all equipment and supplies are sterile, use checklists, focus on 1 to 2 tasks per week, and identify team members responsible for. So allot responsibility to members so that they get used to doing that particular job and they become answerable, so that you can make sure that it is not a collective blame or collective failure to discharge duty. You can pinpoint and find out where mistakes have happened. So that is execution. And then finally evaluate, measurement and feedback. Then develop a data collection plan for all these things, track the progress, give the staff real-time feedback, and identify the causes of defects. So these 4 things you have to include in your answer: engage, educate, execute, and evaluate. And the tools that you can use are daily goal sheet, a 1-page checklist. This tool is completed every morning to establish a care plan, set the goals, and review the safety risk for patient. So this is how the list goes. This picture is taken from Miller. So it says room number, where the patient is, and what is the shift, what is the time, AM, PM. From safety, what needs to be done for patient from the ICU, patient's greatest safety risk, how can we reduce the risk, what events or deviations need to be reported, and pain, sedation, medication, cardiac review, ECG, just like that. Similarly, patient care, what are all the things that you have to do, pulmonary ventilation, SARS infection, sepsis evaluation, and then can catheters be removed, nutrition, all these things which are there in the ICU, and what to do, tests or investigations, what you have to order, consultations from other departments, and description, how much has family been updated, social issues addressed, long-term palliative care. So this sort of things that you have to include, because this is given in Miller, this will be expected in your answer sheet. So this is what is called the daily goal sheet. Then briefings and debriefings. This is to promote effective interdisciplinary communication and teamwork. And this is used to, in ward, in OT, in ICU nursing staff, in the intensivist, or between OT nursing and anesthesia coordinators. Then checklist. So whenever you hand over a patient from OT to PSCU or ICU or CCU, so all of you would have known. You accompany the patient and go and leave them in the ICU. At the time, you briefly describe what was the surgery done, how long it took, what any complication, how much of blood loss, any blood transfusion given in the OT, everything you describe and then hand over the patient. So checklists are used in healthcare to ensure that important steps in a process are not forgotten. Then source of quality improvement information. So that is National Program in Quality Improvement. NPQA is there. And then Surgical Care Improvement Project is there. And private insurances, they help in hospital quality and safety survey. They do that. These are all the sources for quality improvement. So lesson 3 prepared a lot of things about the individual safety measures. So like she said about patient safety, staff safety, electrical safety, environmental safety. So more than that, this is the thing that is given in Miller. I prepared this whole thing from Miller only. So it is better to write what is given in a standard textbook rather than preparing it from some article that you read in a journal or anything. So you remember these points about the, the answer for this particular topic. So to make it concise, remember three things. One, you have to do a periodic review. Then you must think of measures to improve. And third thing is you must form a team to implement those treatment modalities or the changes that you make in the to safe, making the safe treatment safe for the patient. Okay, so in that way you have to think about the both the tools as well as the process how it is done. So if you do that, I think this answer will be, you can write it much more faster, and also it is more appropriate for this particular question. Okay.
Thank you, sir.